Vitale is the National Director of the Pharmacy Partnership for Tobacco Cessation. He's worked in the smoking cessation field since 1987, designing cessation programs, educating over 20,000 health professionals in how to help patients stop tobacco use, and counseling nearly 10,000 patients to quit. He received a Bachelor in Liberal Arts from St. Vincent College in 1974 and a master's degree in psychology from Duquesne University in 1988. He entered the field as a health educator, then as a clinic coordinator for the Lung Health Study. Frank was project director of Lung Health Study 2, a multi-center research program examining the efficacy of asthma in helping individuals with mild to severe COPD regain lung capacity lost to smoking. He also has created a 6-hour CE program, the International Smoking Cessation Specialist Program, which is designed to teach pharmacists how to do smoking cessation counseling, writing the patient support booklets that accompany this training, as well as all of the auxiliary materials. This program has been presented throughout the United States, Puerto Rico, Spain, and the United Kingdom. In addition, he contributed content material for the RX to Change curriculum. From 2007 to 2012, Frank continued to provide cessation counseling training to pharmacists through various projects with the CS2J program. Recently, he designed a cessation training program and intervention protocol for psychologists in Beijing, China, as well as for the Hy-Vee grocery chain in 8 Midwestern states. So, let's present Mr. Vitale.
Thank you. Thank you. I told her to say he's old and he's done this a long time, so just sum it up a lot easier. So that just gives you a little brief. I've been doing this 33 years now, so that gives you a brief idea of the fact that I've been in all the different facets of cessation. Come on in. And I only tell you that since we're a small group. I always like to tell groups this. I want to tailor this as much to what you need as what I have on the slide. So I have had a lot of experience counseling people individually, but mostly the last probably 15 years I've been training healthcare professionals how to do this in their practice sites. And as you just heard, I've done a lot of work with pharmacists, but I've also designed a program for respiratory therapists, emergency room doctors, peer counselors in the mental health field, so, doing all kinds of stuff. And if you want to look and get even more training, there's a wonderful website that the curriculum that I'm involved with called RX for Change that was mentioned. Anybody can access that. It's actually a curriculum for professors in pharmacy schools, respiratory therapy schools, etc. But all the slides have teaching notes underneath them. So if you really wanted to, you could just read all the notes and basically get, pretty much the same lecture you would get if you were in the class. It's 6 hours long, so there's a lot of information there. If you are working with patients or you're in one of your responsibilities is to train other people, there are 8 or 9 different curricula there depending on the specialty. There are 45 videos, sample training, sample counseling videos that last about 3 minutes long, touching upon all kinds of different aspects of cessation counseling. There are role-playing scenarios. There's a million things on this site. So it's at UCSF. The only thing you have to do is create a username and password. It's all free. You can use it however you want, whenever. Okay, so, yes?
Could you say the name of the training again?
RX, as in prescription, for change.
Thank you.
No problem. So I've done this, I've been to the last 2 conferences, and the assumption was that many people came to the introductory lectures I did on cessation. So they asked me to kind of do like a level 2 kind of talk. And again, if you don't know much, well, let me ask you this. How many of you actually do cessation counseling right now as part of your work? Okay, so almost most of you. Okay. So this is kind of like, and I entitled it specifically, what do you say if? Because I'm going to go through all kinds of different objections, problems, issues that you encounter, I would guess, from your patients, and give you some very practical, I'm a very practical person in looking at this, practical things to say, practical things to do to counter a lot of these barriers, objections, et cetera, that you get. So we're just I'm framing this around a basic, very, very basic couple slides on what cessation is, what smoking is. This actually was designed for pharmacists. Judy Oates last year asked me to design a program, a very basic training for pharmacists that's on the Pennsylvania Pharmacy Association website so that they can then become certified so that they can start charging medical assistants for doing cessation counseling. So this is based on that training and it's very close to it. So if you see the word pharmacist in there, that just means I forgot to change it when I updated it for here. Because I realize all of you are not pharmacists, or most of you. Are any of you pharmacists? You are, okay. Good, we have one of them. All right, so again, some real basic stuff at the beginning here that I'm sure you're all aware of. I've been doing this, as I said, all these years. This statement was made in like 1982, I think, and it's still, unfortunately, even though we've made huge progress, it's still the leading cause of death and disability in the US and in the world. Part of that is because as people my age, as we get older, many more people in my generation smoke than in your generation. So this is when they're getting ill. It'll probably be another 20 or 30 years before we actually see the numbers of people getting ill from smoking actually dropping. It's still around 450,000 people die every year from smoking-related illnesses. So there's a lag time there. Now the good news is, as you can see, back in the 50s, it was 60%, close to 60% of males. My dentist smoked while he worked on my teeth. He had a cigarette in his mouth in his office, and my mother never understood why my sister and I hated going to him. So even doctors, nurses, dentists, et cetera, smoked back then. Now, we see it's about 15%. We know, and this is, if you've ever attended any other kind of trainings, most people do want to quit. And many, many people try. The problem is, this is what 99.9% of people do when they quit smoking and why they fail. What am I doing right now? No. Nothing. It fascinates me. After being in this field all these years, I mean, think about our culture. If you have alcohol problems, what do? You go to AA. Everybody knows that. If you have drug problems, you go to NA or a counselor. If you have psychiatric problems, you go to a therapist. Our culture somehow or another thinks that you just have to say to yourself, I'm going to quit smoking, hide the cigarette somewhere, and bing, bang, boom, you click your heels 3 times and you magically quit. The problem is that obviously you all know that doesn't work. There are a few people that can quit cold turkey. I don't deny that, and sometimes it works. But the reality is it's less than like 3 or 4%. So the issue here is that you need help. You need a plan. You need to do something. So what we're going to talk about here is the behavioral stuff, which is on this side of the equation. And then what else are we dealing with? Smoking is a behavior, but it's also what? An addiction, right. So there are 2 parts to smoking, so there's 2 parts to quitting. And you have to do those simultaneously in order to quit successfully. So what we're talking about today is the behavioral stuff. Now, I'm not going to be talking about any of the products. Unfortunately, there's not enough time to talk about that. But pharmacists are trained to know all about the medication. So if you have a patient that wants to quit, I would strongly encourage you to refer them to the local pharmacist. This RX for Change program is now in like 90% of the pharmacy schools in the country. It's been there for the last 20 years. So almost every pharmacist in almost every pharmacy school has had some cessation training. Now, one thing you can do with the products. So they do nothing to behaviorally when they quit. What happens with the products? Well, why doesn't any medication work?
You don't take it.
Yeah, you don't take it how?
As prescribed.
Correctly, okay? Now that's very important here. You don't take it correctly. Oh, this is about 15 years ago. I did a study with SmithKline Beecham where the patch, the gum, and the lozenge are over the counter, right? Those are the three products that are over the counter. You're all probably familiar with that. So we wanted to see how people use them in real life. So we got 200 people in Pittsburgh, 200 people in Baltimore. We gave 1/3 of them the patch, 1/3 of them the lozenge, and 1/3 of them the gum. Didn't say a word about what to do, anything. And then we followed them. Now I was the one that did this study. At the end of the study, we called everybody by phone and I asked a bunch of questions. And one of the questions was, did you read the directions on the box? Now you can imagine, because I'm telling you this, the answer was predominantly no. That didn't surprise us. What did surprise us was this. Every single person that had the nicotine gum said this. I would say 80% of the people had the patch and about 75% of the people who had the lozenge. What directions are you talking about? How stupid do you think I am that I don't know how to chew gum? Those patches are just Band-Aids, aren't they? You just plop it on. Those lozenges, you just eat them like candy, right? So with this class of medication, not only don't they read the directions, they don't even know they're there. So one easy thing all of you can do with anybody quitting is simply, refer them to somebody to talk as a pharmacist, as I just said. But if they have a product, make sure they understand how to use it. Make sure they've read those directions. Turn them over if they can't read, and read them for them, explain them. It's a very simple, very powerful intervention that we forget about because we just assume everybody knows how to use this. And by the way, you should not chew that gum like chewing gum. It doesn't work if you do that. All right, so we talked about the disparities. We've already talked about this, and you've already been here, so you know most of this from your own training and your own background. As the general population quits smoking, we see it now being congregated more and more and more into lower socioeconomic, LGBT, mental health, all of those kind of disparate groups. We are seeing higher and higher rates, so we are now focusing on these areas. I'm part of a group with UCSF. In fact, tomorrow I'm going to do a training in Portland, Oregon. We're working with all the mental health facilities in the country to help them go smoke-free, number one, and number two, help them help their patients to quit. So there's a national focus on this happening. We talked about this. It's still the leading cause of death and disability. The simple point here now is there is clear evidence that it affects every single part of the body, head to toe, inside out. There's nothing that escapes. And so from your perspective, other than a psychiatric problem, if the person has a physical illness, smoking is either causing it, it's exacerbating the symptoms, or we know smoking impairs immune response. So smokers don't get well as fast as non-smokers, and they get sick more often. So from the physical side, it's affecting it some way or another. So as I just said, this is a two-part behavior. So in order to quit successfully, you have to deal with both parts. It's an addiction. Nicotine is truly addictive. It hits the brain in 11 seconds, and it causes the brain to release dopamine. And because it's so much and so fast, the brain, the body, the person really likes it. In fact, they love it. But nicotine has a very short half-life. So the moment you hit that high, the very moment you stop smoking, that level begins to drop and drop and drop and drop and drop until about 45 minutes, hour later, the person's in what? Withdrawal, right. And that's irritability, anxiousness, restlessness, impatience, all feelings that we don't like. So how do you get rid of that? Smoke another cigarette. So all day long, you're going up and down and up and down and up and down. The products, on the other hand, give you a nice, steady amount of nicotine. It's just enough to keep you out of withdrawal, but not enough to get you addicted. Because all the products that are nicotine replacement products give you nicotine at a slower rate and a lower amount. So you cannot become physically addicted to any of the nicotine replacement products. So that's why we recommend that you use them, because then you can slowly taper yourself off of those. So that's that part in a nutshell. So here's how I'm going to do the rest of this. Is I've just put these quotes that I've had people tell me all the time. So we'll look at the myth behind it, and then the reality. So when we're talking about withdrawal, many people have tried going cold turkey, and they feel miserable, and rightly so. Those are very, very real feelings. But what they convince themselves is that this is going to last forever. I'm going to feel like crap all the time. The only way I can stop that is to smoke. So we have to really counter that by helping people understand that the medications are there. They do work if you use them properly. And by the way, if you have somebody that says to you, I tried those stupid patches and they don't work, or that gum was crap, I can guarantee you they didn't use it correctly. Absolutely guarantee you. So that's the question you want to ask them. How did you use it? And then work with them there. Even if you don't use a product, the nicotine is generally out of your system in 5 to 7 days. Withdrawal symptoms generally go away in a couple of weeks. And if somebody tells you that they had a craving for a cigarette a year after they quit, that's not really a physical craving. It's what?
Psychological.
It's a thought. Yeah, it's a thought. So, okay. Now my reaction is, okay, so you had a thought about it. They invest all this meaning into that when it doesn't. It has no meaning whatsoever. It's just a random thought that popped in their head because of some situation they were in or some feeling they were feeling. So don't make a big deal out of that, because they're not. The habit, Pavlov's dogs, I don't need to explain any more than that. That's all it is. And if you think about it, if you're in withdrawal and you're going up and down all day long, and every 45 minutes to an hour you have a cigarette, for most people they're smoking what, 20 or 30 cigarettes a day while they're what? Doing everything else in their life. So what Pavlov showed was that doing one behavior after another over and over and over and over again, links the two, so much so that doing this one unconsciously and automatically prompts you to do this one. So what happens is that people start, or after 6, 8 months, a year of smoking, that habit is connected very strongly. So here is where, if any of you attended the other lecture on the research project they were doing, they were looking at what do we do differently with LGBT? What do we do differently with men? What do we do differently with women? The fact of the matter is, every single cessation program should be individual based on all of this. Everybody has some kind of different pattern or routine to their smoking. There are people who go out and go out on a Thursday night all the time and have a drink in a bar and that's where they smoke. And then there are other people who never go out and they don't drink alcohol at all. So person number 2, you would not be talking to them about how to handle being in a bar, because it's not pertinent to them. So every smoking cessation program should be individualized. Now, there are lots of commonalities, so that's where what we're talking about today comes in, because many of these things will happen with many different people, and you need to know how to deal with them. So the idea here is that, remember one word, only. Smokers think the only thing they can do after a meal is to smoke. The only way I can have a drink in one hand is to have a cigarette in the other hand. The only way my car will start in the morning is if I have a cigarette in my mouth. So they have taught themselves unconsciously that these things are so linked that that's the only way to deal with them. So our role here is to teach them alternatives. There always is some other way to behave in a situation that doesn't trigger you to want a cigarette, or some other way to think. So if you look on the left, those are all behaviors. On the right, what are those? Moods. So your moods can trigger a desire for a cigarette just as much as the situation. Now, I've had people actually say this to me. I just smoke all day long, everywhere, no matter what I do. I have a cigarette in my, how can I possibly stop doing everything in my life? Well, that's not the point here. And number one, that's simply not true. Nobody smokes that much. Although I did have one man smoked 6 packs of cigarettes a day. That's 120 cigarettes. He worked at the post office on one of those, on the belt sorting, and he would just light one right after the other. He's the only person in my entire career that I got down to 1 pack a day and was happy about it, because that was just unbelievable. But putting him aside, you just don't actually really smoke all day long, and you can learn to deal with these triggers. Those are called coping techniques. So anything that you'd be doing with people individually, or if you call the quit line or any program, that's what they're doing. They're teaching them how to cope with those triggers without having a cigarette. All right, so that's just a little primer on what smoking is, so what can we do to help somebody? Well, here's the basic protocol that we have for pharmacists, because we know that in most cases pharmacists don't have the time to actually go into a whole big, long cessation program. So it's ask, advise, refer. So that's how that's the framework for the rest of the talk here. So my advice is that we all need to ask every patient every single time. Because, and I'll get this, I'll repeat this because I think it's very important. You just might be the person that particular patient will pay attention to. So you need to know whether or not they are smokers. So it should be in your electronic records. It should be somehow or another flagged. Now, if you have a 90-year-old woman and she has never had a cigarette in her life, I don't literally mean you have to keep asking her every single time. But I think we need to get into the habit of making sure that this is part of our documentation, no matter what our profession is or what our role is in the process. Many of us have seen patients for years. So what does that engender? Trust. So they know you, they trust you, they pay attention to what you have to say. You know their history, so you know what is going on with them medically. And then you know other resources. When I do these trainings, I always ask people about quit lines. And I would say in most trainings, less than half of the health professionals in the room have ever heard of a quit line. So if they don't know about it, most of your patients don't know about it. So one of the things you can very quickly and simply do is to have a resource list of where to send patients to get information about quitting. And the quit line is one of them. It's a very simple thing to do. All right, so when you do this online, this person actually says what's on here. So I was trying to make it a little more interactive. So what I want to do with this is ask you the question. How would you respond? So, since when did pharmacists start asking us about smoking? If you're a social worker, so when did social workers start asking? If you're a respiratory therapist, so just insert your profession in that line. What would you say if a patient said that to you? I will ask the pharmacist. If somebody said that to you at the pharmacy counter, how would you respond?
Because it's not just medications. I just want to make sure that your total health is covered. And smoking is a big thing that you can control over. There's a lot of diseases that you don't have control over, but smoking can definitely add years to your lifespan. So
Quitting smoking.
Quitting smoking. So I just wanted to make sure that all of my patients are doing well.
Good. Yeah, so it's as simple as saying I'm concerned about all my patients' health. Or we know, as you said, we can prevent a lot of illnesses if you quit. So think about that. If somebody challenges you, come up with how you would phrase that or what you would say. Now, I like to let people know about this because most people don't know about this. There are drug interactions between the hydrocarbons in the smoke and many medications. Okay? So, many medications are metabolized through the CYP1A through pathway in the liver. I don't get caught up on the science here. What it does, these hydrocarbons rev up the liver so that they metabolize these and a lot of other medications at twice the rate they normally would. So guess what? If you quit smoking, you're going to need less medication. Now, are many of you in the behavioral health or mental health field? Okay, what is the one general thing we can say about almost every psychiatric patient, every behavioral health patient is they hate taking medication, okay? So if you can offer them a way to take less medication, that may be another motivator for this person to quit. So this list, and you can see a lot of them are psychiatric medications. This is by no means an exhaustive list. If you go on the RX for Change website, you will find a list of everything that's there. This is very important because what happens with people who are on many of these medications, if they quit smoking and they stay at the same dose, what happens? They're getting too much medication, they're getting side effects from getting too much medication, but what do they think it is?
The fact that they've stopped smoking.
That's the fact that they've stopped smoking. You're absolutely right. They think it's withdrawal because they've stopped smoking, so they go back to smoking, and guess what? All those symptoms go away because now, the effect is happening again. So the reason I bring this up and I try to emphasize this is that if you have anybody quitting, make sure that their doctor is monitoring their medications and in most cases lowering the dose. Yes, sir.
This may be a naive question, but I'll throw it out anyway, which is that if a physician is prescribing medication for a patient, let's say a psychotropic medication, you would think that they would be doing a history to know if that person is currently smoking or not smoking. You'd also think
One would think, yes.
One would think that, and you would also think that they would understand that if the person is smoking, they would then be underdosing the person with the medication that they're getting. So, are physicians actually prescribing medications and not screening for smoking?
Yes. Yeah. I would say in most cases they don't really pay any attention to that. Yeah. And what they're doing, to your point, so what they're doing is they're giving them, 10 milligrams of something and it doesn't work, so then they, after a week or two, then they up it to 20 milligrams, when it should have been 20 milligrams based on the fact that they're smoking.
Right. So they're not factoring in the decrease of the medication that they're prescribing.
There are no doctors in here, are there? No. Do not assume the doctors even ask their patients about this. Out of all the health professions, they have the least good record on asking about this and actually incorporating it into their practice. Now, I would say pulmonologists know, cardiologists pretty much know. So if you're looking at specialties, yes, but in general, no. You got to. So that's why, we all have to be aware of this.
Thank you.
No, that's not a naive question at all. Now, I'm going to put you on the spot again. There's one class of medication that you should be asking about their smoking status all the time, because just the fact that they're smoking increases the risk of having certain adverse events.
I don't know what you're trying to do.
All right. Oops. Oral contraceptives. Okay? So, with your female patients, anybody on oral contraceptives, now this has nothing to do with nicotine or anything else. It's the fact that smoking increases those risk factors. Oral contraceptives increase those risk factors. So the combination of the two, especially if you're over 35 and you're smoking more than 15 cigarettes a day, significantly increases your chances of having a stroke, an MI, or an embolism.
I'll also add that our clinic does trans care. So for our trans females that are going on estrogen,
Wow,
we do talk to them
Yep.
about smoking cessation and realizing the risk of clots and their risk for cardiovascular.
Right. Yeah, for this population, absolutely. Anybody on estrogen, should change it to that. Yeah, you should be very careful. So if they want to stay on that estrogen, they need to quit smoking. If they don't want to quit smoking and it's for contraception, then they need to use some other kind of contraception. So I'm just giving you this, not to get too technical, but to give you another motivator for people that you can now say, hey, you're really putting yourself at risk. And this is not theoretical, by the way. I know of women who've had strokes in this situation. So yeah, it does happen. It's in the literature and it is real. Okay, so to his point, I can't tell you how many times I've heard this. Well, Fred, why should I quit smoking? I just saw my doctor, he never said a word about it. Or I just had respiratory therapy treatment and they never said anything about it, so how bad could it be? And guess what? I would think that. Because the reality is, that's human nature. If your doctor's not saying anything, if the nurse isn't saying anything, the respiratory therapist isn't saying anything, how bad could it be? So this is where I really advocate that if you don't ask, if we don't ask, the patient walks away with the impression that it's not important to quit and that smoking's no big deal. Back on that third slide, I said like 70% of people want to quit, and that's been held to that number for a few years and years and years. And I'm not doubting that. But I would say 90% of that 70%, that little voice in the back of our heads that we all have is desperately trying to find an excuse to continue to smoke. So if you don't say anything, you've inadvertently given them permission to continue to smoke. Now, so we're just asking the question here. Now, this used to be easy until about 5 years ago. So I would used to say, just ask, do you smoke or use any type of tobacco? Now you have to go into, nicotine products, vaping, Juul, all that kind of stuff. So it does become rather cumbersome. So I would just say, do you use anything that contains nicotine? I think that's probably the easiest way just to cover everything. And then again, when somebody's saying, why are you bringing this up? What's the point? Then here's other things you can say. I think you get a copy of all of this, so you'll have. And again, I don't want you to actually use these quotes, but put it into your own words. But I like to give you that kind of structure there about what to say in all these different situations. All right, so that's asking. We now know the person smokes. How should we advise somebody to quit smoking? Should you walk up to somebody and say, you better quit smoking tomorrow, you're gonna die? No, obviously not. If you use those exact words, if you tell somebody they're going to die from smoking, what are they likely going to say to you?
Gotta die from something.
You gotta die from something. And guess what? They're right. That's not what this is about. This is not about dying. Okay, and by the way, this is how most smokers think they're going to die from a smoking-related illness. If you talk to them, they think that they're going to instantly collapse on the ground, the angels will take them to heaven, and bing, bang, boom, that's it. What's the reality? Slow, lingering, painful life before that happens. So this is not about dying from this behavior. It's about, can you live with the consequences of what you're doing?
Quality of life.
Correct, absolutely right. So here is, especially if you know your patient, and that Joe likes to go fishing. Well, and he's got COPD, and if he continues smoking, he's going to be on an oxygen. And those machines make a lot of noise. So Joe, what would it be like if you're out trying to fish, and every 30 seconds there's whoosh, whoosh. That's going to disturb the fish. So how could you go fishing with oxygen tank behind you? So what you want to do is to focus on how this is negatively impacting their life. And so the question becomes, the overall question is, can you live with the consequences of this behavior? What would it be like, Mary? You told me you just have a new granddaughter, and I know you want to be around to see her get married because you told me that. So what would it be like if you weren't there for her wedding? How would it be if you can't go fishing anymore? So you want to ask these types of questions. What 2 words did I use to begin all those questions I just?
What would?
What and how. So those are the hallmarks of open-ended questions. So you want to ask such provocative questions and give them such powerful information that they are going to tell us they want to quit rather than us telling them they have to quit. So that's what advising is about. It's not doing this, it's not hollering at them. I have never, ever in all these years told anybody they had to quit smoking. Those words have never come out of my mouth. Because they really don't. It's their choice. But what I have done is ask those kinds of questions because then it becomes, well, yeah, Frank, I really want to be around to see, little Susie grow up. I want to be able to take my kid to, play ball with him or whatever it is. I want to have a nice retirement and I want to be able to blah, whatever. But you only get to those things if you ask how and what questions. Those open-ended questions. Because that engenders a conversation. If you just say to somebody, don't you know smoking's bad for you? They're going to say what? Yes. That's not a conversation. That's just a question and an answer. So you really want to get into those kinds of questions. Now, what was your question?
This may be a nuance that you're going to talk about later, but in order to have that kind of conversation, Mary, what would it be like for you to not be at your granddaughter's graduation? You would have to know
Yes.
that being at Mary.
Correct.
You would have to know she has a granddaughter.
Correct. Yes, absolutely. Yeah.
So can you say a little bit, because there's something that has to precede the what would it be like?
So
without-
yes, you have to base this on the information that you have. So if in many cases it may just be the fact that they're in for some illness that's being treated. So you can kind of extrapolate from that or ask if, and so I don't literally mean every single question has to be an open-ended question. Yeah. That's a very good point because you do have to gather some data. Right. So that's if you have the time and you can get a little bit of information, okay, what are your plans for the next 10 years? Or I know you're 63, you're close to retirement. What do you want to do? So yeah, you have to get a little bit of. I'm presuming that in many cases, many of us know these people because we've seen them over and over and over again and have some kind of relationship with them. But yeah, you're absolutely right. You have to have some kind of data to base that on. If you don't, then you can go into these more general statements. Like it's the single most beneficial action you can do, et cetera, et cetera.
So would the quit lines, like the PA quit line, would they have literature or product or posters that they
Yes.
can send for
Yes.
like my office? So whenever I see patients,
Yes, they have all that.
that
just
suddenly
call.
it's up and it sort of generates that, oh, I see this
Sure.
sign over here.
Sure, absolutely. Just call that 1-800-QUIT-NOW number. Tell them what you do and that you want this stuff. Yeah, and they'll.
Is that no cost? Gotta look at budgets.
Yeah, it's all free of charge.
Oh, free charge.
It's all free. And if there's an issue with cost, call Tobacco Free Allegheny and they can supply stuff too.
Yeah, they have posters, little business cards, different types of posters.
Okay.
The sample posters are online, so if you want to be like, oh, I want this in Spanish, there's a Spanish one, and then
Okay.
they have all types of that, and it's all free.
Yeah, I think if you
Also,
go to,
every county in the state of Pennsylvania has partnerships. I know we're in Southwest and we're through Adagio. That's the partner with the Department of Health. But we go out and do the cessation classes. We go out and do the prevention. We go out and give the information out. So every county has someone you can contact.
Okay.
So if you go on to Department of Health, it should tell you who's going to be handling that county with telephone numbers and names.
Thank you.
Cool, good. All right, we're running a little short of time here, so I'm just going to jump into some of these specific situations here. Okay, here is probably the biggest excuse you'll hear from patients about why they don't want to quit and why they've relapsed. So they say smoking helps me deal with stress. The reality is this: smoking causes stress. All that up and down and up and down and down. Every time they take that puff, their heart rate and blood pressure go up, and then when they stop, it goes down. So it physiologically is causing a lot of stress. Now, I don't deny that some people feel more calm and relaxed when they smoke. So what is really happening?
What they're doing is they're taking a deep breath.
Right. So
And
number
that's
one,
the first thing they feel relaxed.
they're doing exactly the same kind of deep breathing that they teach you in yoga, meditation, and ladies, Lamaze, when you're having a natural chakra. Deep breathing does calm you down and relax you. So they're doing that. They just think they have to have this thing in their mouth in order to do it, okay? So that's teaching point number one. No, you don't have to have this thing in your mouth. It's the deep breathing. What's the second thing?
They go for a smoke break.
Correct, absolutely right. So you've all heard this lecture before. You know? So where does stress come from? Not a trick question.
Depends on the person.
Surroundings.
It's either it's how
People
you
play-
perceive the situation.
Right, she's right. It's not just surrounding, it's how you perceive the situation that you're in. You have to go to the dentist, I have to go to the dentist, we're having exactly the same procedure done. You walk in there and say, I don't need any Novocaine, just fill it, I'll be fine. I, on the other hand, am standing in the doorway, shaking like a leaf, there is sweat pouring off of me, I am scared to death. What's the difference between her and I?
Perception.
The perception of the situation. She perceives it as no big deal. I, on the other hand, think he's going to kill me. So that's where the stress comes from. So to her point, if I'm here shaking and all of a sudden I light up a cigarette, what am I doing?
You're coping with it.
By what? By shifting the focus from worrying about, because what am I doing? In my head, I'm going, ooh, this is going to kill me, and blah, 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 blah. The cigarette helps you shift the focus, but it's a tool that you're using. It isn't doing that for you. So again, the word only comes in here. People think they can only, that's the only way to shift focus. And as you know, there's a million other things you can do. Third thing, and probably most importantly, what does stress feel like? It's irritability, anxiousness, restlessness, impatience. What did I just use those 4 words to describe about 20 minutes ago?
Withdrawal.
Withdrawal. Absolutely right. Stress and withdrawal feel exactly the same. When a person smokes a cigarette and they feel better, it's because they got rid of the withdrawal. But because these two things feel the same, they mix up getting rid of withdrawal with getting rid of stress. And if you're doing this, all day long for most of, for 10, 20, 30 years, you start to very firmly believe that this thing is doing this rather than the reality is if you didn't have that nicotine in your body to begin with to drop, you wouldn't be in withdrawal, et cetera, et cetera. So there's those 3 elements are really what's happening. And I could spend another 25 minutes talking about that, but I only have 10 left, so. Yeah, there's a lot there. So in reality, what we're doing with many of these people is teaching them how to cope with stress. Because what have they done every time they've been in a stressful situation? They've gone and smoked. So they really honestly don't know how to deal with stress. In many, and I'm making generalities, as you know, I'm not speaking for everybody. All right, weight gain. The average smoker gains maybe 5 to 7 pounds when they quit. That is because of the very slight metabolic shift that occurs with not having nicotine. Now, if you gain 50, 60, or 70 pounds after you quit, what's the issue? What's the problem? It's you.
Agreed, yeah.
What are you doing?
Yeah.
You're doing this. Think about it. You put a cigarette in your mouth, maybe one cigarette you maybe, take, 100, 20, 30, 40 puffs on it, and you're smoking 20 or 30, 40 cigarettes a day. So you're doing this 400, 500, 600 times, depending on the person and how many puffs they take. So again, it's habituated, it's a habit. So when this goes away, you miss it, the oral gratification, so you start putting food. Now, are you eating carrots and celery and radishes and... No, what are you going after? Junk. Why is that? Well, your taste buds are pretty much deadened when you smoke. You really can't taste very well compared to a non-smoker. And what is the one ingredient in food that gives it the most taste?
Sugar.
Nope.
Fat.
Fat, absolutely right. So not only are you eating more food, you're eating more fatty food because all of a sudden it just tastes incredible. So again, this is a behavior thing to deal with. I always like to say this, I tell this to patients. Nicotine does not turn your body into a fat burning machine, or else you would be this thin and would all look like, I don't even know who's that thin anymore. I always used to say Twiggy until I was at a college about 20 years ago, and the kids raised their hand and said, who's Twiggy? Now, you know who Twiggy is. Does anybody else know? You do. You all do? Okay, good. You're a very well culturally educated group. So I had to change. And then I said, I don't know who else. I said Britney Spears, but she got heavy. So
Olsen twins.
The Olsen twins. Yeah, the Olsen twins. Those would be good, yeah. Yeah, so you don't, not every smoker looks like that. That's my point. Okay, I love this. I can quit anytime I want. Well, no, you can't because, why haven't you before, this is just an excuse all addicts use. And my friend Karen, she says, well, what is the benefit of waiting 5 more years to quit? So again, that's kind of forcing them to tell you rather than you chastising them about that. And many people actually do feel they control their smoking, but that's a myth too. It controls you. It's very clear. Okay, everybody smokes. This I don't hear so much of anymore because we have dropped so much, but many smokers only socialize with other smokers. So in their perception, their whole world, everybody smokes. So there are ways to counter that. Okay, so here's 2 ends of the spectrum. I'm only 27. I only smoke when I drink. What's the big deal? Well, what would you say to that?
How often are you drinking?
Well, no, that's a good question. Right. It starts out this way, but very few people can keep it that way because it's a drug addiction. So you need to point that out. And there is no data to support the fact that if you're only 18 or 19, it's not harming you. They've done studies with teenagers and they've shown definite physical ailments, reduction in immune processes, et cetera, with people who smoke. I worked with a girl who was 26 and she had severe emphysema. She was already on oxygen and she died by the time she was 27. So it can happen. Everybody thinks that we can measure everything as human beings that we do on what? A bell curve? So everybody thinks they're over here, but guess what? Half of us are over here. So there are plenty of people who just have a few cigarettes and get ill from it. So it's not impossible. Then on the other end is I'm too old. I've been doing this too long. The damage has been done. And again, there is no evidence to support this. The evidence shows even if you're in your 80s, your lung capacity increases, your chances of getting all these other illnesses drop. The Lung Association has a very nice chart to show you what happens immediately after you quit. And most of the health gains are within 6 months to a year. Now, if somebody's 80 years old and they have terminal cancer and they only have 2 months to live and they're still smoking, I'm not going to have that person quit. There is a point. So, I'm not being fanatical about this. There is a point where you just say, okay, Frank, I've tried to quit 10 times. You know what? That's fantastic. Because you've had a lot of
Experience.
right. You've had a lot of experience. You've had a lot of practice. You now know what doesn't work for you. I'm going to tell you what does. So that's a way of flipping this around from being a negative to, you notice I didn't say, oh, it's good that you relapsed all those times. But so tell me what you did. Let's find out what you did. Let's find out, because I will guarantee you they probably made the same mistake every time they tried to quit. Because they're doing it without support. I review past quit attempts here. Look at what kind of changes they made. One question you can ask a patient in this situation who's kind of discouraged is, tell me what accomplishment you're most proud of. And you may say, well, I paid my way through school, and you might say I climbed, Mount Everest, and whatever the person says to you, the next words out of your mouth are, if you can do that, you can quit smoking. So it's not a magic pill, but it's a nice, quick way to try to change that around. I love to smoke. This person's telling you the only pleasure I have in my entire life is smoking, which again is probably not true. So you need to really explore and help them understand that these products were designed to do this. They're designed to produce pleasure. There's no safe level of smoking. Again, just cutting down doesn't really work. Most people almost always go back up. And then, we've already talked about this a bit, but here, the first question there is the most powerful. What would have to happen to you for you to consider quitting? Now that usually, I can see many people just go, whoa, okay. And then say the person says, well, I have to get lung cancer. Well, guess what? See, and here's the problem with those kind of responses is people think that we can cure everything now. You just go to the right hospital, you either go to Mayo Clinic or Johns Hopkins or some place has a cure for everything. Well, that's not really true. There's a lot of things that, that are problematic. And again, what's it gonna be like having lung cancer for 4 or 5 or 6 years or whatever? So that's a very powerful question. And again, you can, there's a few others here.
It's also another open-ended question.
Absolutely right. Absolutely right. So here are referral sources. The QuitNet and Become an X are online. Quit Now, the Quit Mind card. And again, if you call them in your health professional, they'll get all your stuff set up. They'll help you with all of that. So I recommend that if you're not in this position to do the counseling yourself, that you refer to them. And again, running out of time here, so refer to a pharmacist. Inevitably, they use too little of it. The products are used incorrectly, or they use the wrong dose. So you're referring them can be a big boost to their quitting successfully, and it only takes a minute. Now these are the surgeon. Everything that I was talked about is in this clinical practice guideline. You can get a copy from the Surgeon General. This is a meta-analysis of over 8,000 research projects, but 8,000 studies. It's the gold standard of cessation. So if you're really getting involved in this, I'd recommend getting a copy of that. It's really very readable. And then this is the RX for Change website. And this is my contact information. So I'm on the south side, so if you're walking through the south side and you see me, just stop and say hello. All right, any questions? Thank you. Do we have one?
Well, after this is just a little bit of a break. So we do have some time right now if you guys don't want to do like the poster session outside and you want to stick around and do some questions.
Yeah, I'm here, so if you want to ask questions.
What role do those the new product that's just nicotine pouches, I see them sold at like Sheets or wherever, instead of buying Copenhagen or Skull, now they sell these pouches that are just
Yeah, that's
nicotine
called
tobacco.
snus, S-N-U-S.
So
And so that comes from Sweden, and it is actually pasteurized tobacco.
There's a new product that's like,
Yeah.
I-Tech, it's the same thing.
You know what? I'll be very, there are so many new things coming out every day. We're having trouble keeping track of them. Yeah, it's similar. You know, tobacco's tobacco. There's no safe form of it. So yeah, none of that is any good.
Thank you for the presentation. And, you know, hearing you talk about this makes me feel so hopeful for people that they can actually, you know, choose to stop smoking. And I'm just curious from your perspective, you know, you're talking about facts and information, and oftentimes I think when smokers are talking about their behavior, they're talking about feelings.
Yes.
So given that the facts and the information add up to a very clear and distinct picture, why do you think that these approaches are so ineffective in response to the feelings?
What is your profession?
I'm a social worker.
Okay. So I leave out the part about all of that in most of these talks because most people, you know, a pharmacist can't really get into that with somebody, or a respiratory therapist, but that is what you're talking. There's a psychological dependence in addition to the physical addiction and the habit. So yeah, you have to deal with that. And that's what, if you get into a program or a group, that's what they'll be talking about. So it's that belief that smoking is beneficial. By and large, we as human beings generally only do things that we perceive as beneficial, okay? So a smoker thinks that smoking's doing something that they can't do for themselves. And that it's something that's so important that they can't function without it. So it is that whole thing about it gets rid of all my stress. It's my best friend. You know, I've heard that a million times. So yeah, yes, if you have the capability and the desire to get into that, that is very important. However, there is a segment of the smoking population that these techniques will work beautifully for, who don't know any of this. So yeah, there is no one, there's not one way to do this for everybody. But yes, if you're comfortable going into all of that, then I definitely would. And what I do with most of those individuals who have that, and they're generally the people who are having all these horrible physical ailments and just won't let go. There is some really strong belief that they can't live without cigarettes. So it's really helpful to have them explore that. And then what I do, and this may sound kind of strange, is I frame it as a relationship. It's an abusive relationship. Yeah. It's the same thing that Tina Turner sings about. And so you really have to get to the point where you have the person say, you know what, I thought I couldn't live without you, and I love you, and you've been here for 30 years, but you're killing me, man, and I can't take it anymore, so get the hell out the door. So, and that's really where you want them to be psychologically. Yeah. So you want them to break up with the cigarette.
Yeah. The point, though, that I think is so meaningful about what you just said is that they have to say that.
Correct.
Somebody saying that for them
Correct.
is not going to be the
So
same.
that's where the motivational interviewing comes in. That's where the questions come in. Absolutely right.
Thank
you. I have had people write. They'll make you cry. I have people, women especially, because women are more relational than us for the most part. And I've had this one woman, I was crying reading this thing. It was like, you were my best friend. She was a nun at a Roman Catholic nun, and she started smoking while she was in the convent because she got mad at the Mother Superior and thought this would be a good way to get back at her. And afterwards realized how stupid that was. But she left, and she left the convent. She was by herself for like 8 or 9 years. That was the only thing she had. And and until she did that, she wasn't able to quit. But once she did that, she wrote like a Dear John letter. And once she did that, it was done. So yeah, that's a very good point. But again, I don't generally get into that in these general talks because most people are not comfortable doing that.
Thank you.
You're welcome.
Any other questions?
Well, I'm here for the rest of today, so if you have any questions.
Thank you.
Thank you. Thank you.